Have you ever walked out of a doctor's office wondering if you were really heard? Or questioned whether your age silently shaped the way your concerns were treated? For millions of seniors, these aren't abstract questions, they're everyday realities. In today's video, we're uncovering 6 shocking truths about how older adults are treated inside the healthcare system. These insights are grounded in research, patient stories, and real medical practices. By the end, you'll not only understand what's happening behind closed doors, you'll also know how to protect yourself and demand the care you deserve. Before we begin, make sure to subscribe to the Mental Dose channel and join our Telegram community, where you'll get early access to new videos and insights on personal and spiritual growth. Now, let's get started. 1. The bias that starts before you speak. From the instant your date of birth appears on the chart, the visit is framed. In busy clinics, age becomes a proxy for complexity. More meds, more comorbidities, more time. That label quietly shapes behavior: shorter listening, faster interruption, quicker default to templates. Research in geriatric care consistently shows that older adults are more likely to be treated with heuristic shortcuts rather than hypothesis-driven reasoning, which increases the risk of misdiagnoses and undertreatment. This isn't usually malice, it's throughput pressure plus mental load. 10 to 15-minute slots incentivize pattern recognition over investigation, and age becomes the pattern. The fix on your side is strategic, open with a clear goal. In the last 8 weeks, I've lost half my walking distance. I want to identify why and what to test next, and hand over a 1-page up-to-date summary of your meds, allergies, and key labs. That reframes you from complex to organized partner, which measurably improves the depth of clinical reasoning you'll receive. And as that initial frame sets the tone, another, more systemic force often tightens it: the economics behind the encounter. 2. When money quietly steers care. Modern medicine runs on cost-benefit logic. Concepts like quality-adjusted life years, QALYs, and insurance policies don't live in the exam room, but their gravity pulls decisions there. In practice, this can mean fewer high-cost tests, less aggressive therapy, or a swift pivot to conservative management for seniors, even when clinical benefit is plausible. Health economics research has documented how age can act as a silent weighting factor in access to advanced therapies, transplants, or oncology options. For patients, the signals are subtle. Phrases like "at your stage," are "not worth the burden," or "marginal returns" appear early, sometimes before staging is complete. Counter with precise questions: given my current functional status and comorbidities, what's the expected benefit and risk of option A versus B? What evidence do we have for patients my age? Asking for numbers, absolute risk reduction, number needed to treat, forces the conversation back to medicine, not money. And even when cost isn't explicit, another shortcut often is: dismissing new symptoms as nothing more than aging. 3. The just aging trap. Normal for your age can be reassuring, or it can be a door that quietly closes on real pathology. Literature in internal medicine shows that symptoms in older adults are more likely to be attributed to aging before appropriate workup. Heart failure dismissed as fatigue, inflammatory disease as stiffness, thyroid disorders as slowing down, depression as adjustment. The result is diagnostic delay, which in seniors often means falls, deconditioning, and preventable hospitalizations. The antidote is data. Anchor your concern to a timeline and a clear change from baseline. Until April, I walked 4,000 steps daily. For 3 weeks, I've struggled to reach 1/500 and now need an afternoon nap. Bring logs of blood pressure, weight, or activity. Objective changes are harder to ignore. Then ask, if I were 45 presenting like this, which tests would you order first? That forces differential diagnosis thinking instead of age-based reassurance. Of course, even when your symptoms are taken seriously, another bias often limits the care you're offered: the assumption you won't manage complexity. 4. Underestimating seniors' abilities. Too many doctors assume seniors can't handle complex information or advanced treatments. Research in The Gerontologist shows that older adults are often excluded from discussions about clinical trials or innovative therapies, not because they're ineligible, but because physicians assume they wouldn't want the complexity. The result is oversimplification. Fewer details, limited options, and regimens chosen for convenience rather than effectiveness. Break that loop at the start. Signal capacity and preference. Please give me the full range of options with absolute benefits and risks. I take notes and review everything. Ask for proper vocabulary and request decision aids you can study. If you worry about memory, bring scaffolds, written plans, teachback, or a trusted advocate who helps capture details without speaking for you. Demonstrating engagement and literacy flips the bias, showing you as a capable partner in decision-making. And when information becomes treatment, one domain can either restore function or quietly suppress it. Medications. 5. When medications manage behavior instead of disease. Polypharmacy is common after 65, but the danger isn't just the number of pills, it's the purpose. Investigations have shown inappropriate use of antipsychotics, sedatives, and other high-risk drugs in older adults, sometimes to calm or settle behavior rather than treat disease. The risks are severe: falls, delirium, memory loss, and even increased mortality. Meanwhile, effective therapies for proven conditions may be underused, compounding harm. Your safeguard is clarity and review. For every prescription, ask, what condition is this treating? What outcome are we targeting, and how will we know when to stop? Request periodic comprehensive medication reviews by your primary clinician, a geriatrician, or a pharmacist. Many seniors discover they're taking drugs with no clear medical purpose, and when sedatives or psychiatric drugs are proposed, insist on documented diagnosis, shortest possible duration, and a plan for tapering. Non-drug interventions, better sleep hygiene, physical therapy, cognitive support are often safer and more effective long-term. Before we go on, if this video is helping you see things more clearly, consider sharing it with someone who needs it. And if you'd like to support this kind of thoughtful content, you can click the thanks button below. Your support truly helps. Now let's continue. 6. The hidden calculation of life value. In hospitals and insurance offices, age is often factored into treatment decisions in ways patients never see. Quality-adjusted life year models reduce older lives to fractions of value compared to younger ones. This influences whether you're offered certain surgeries, scans, or aggressive therapies. The consequences can be devastating. Seniors with identical health profiles to younger patients are sometimes steered toward comfort care instead of curative treatment, not because the therapy wouldn't work, but because the system devalues the years they have left. Emergency medicine studies show that older adults with the same presenting symptoms as younger patients are less likely to receive advanced imaging, specialist consults, or ICU admission. The best defense is to challenge assumptions directly. Ask, would you recommend this if I were 45? Insist on medical, not economic, reasoning. Research survival and treatment outcomes for your age group and bring that evidence with you. Your life has equal value, and demanding equal access to treatment is the only way to push back against systemic discrimination. Now you've seen the 6 most shocking truths about ageism in healthcare: unconscious bias, economic rationing, dismissing symptoms as aging, underestimating intelligence, and the misuse of medications. Together, they paint a picture of a system where seniors are too often undervalued. But knowledge changes everything. Seniors who document symptoms clearly, demand evidence-based care, and challenge dismissals consistently achieve better outcomes. Your life is not a calculation. Your voice matters. And the more you use it, the more you transform not only your care, but the system itself. Have you ever experienced medical ageism? Share your story in the comments below. We want to hear from you. And if you found this valuable, don't forget to subscribe to Mental Dose and join our community for more content designed to empower and protect you. Together we can demand dignity, respect, and equal healthcare for every stage of life.